Good afternoon once again. Now I'm in a very uncomfort situation because one of the leading experts of this field with 35 years of experience described almost all physiologic mechanism, and now I should bring some new to this topic. So I apologize because I will continue with the basic fact which has been already mentioned by Einar. Plana vitrectomy is an operation introduced by Robert Machamer in the early 70s, so the history of this operation approach into the eye is not long. This is how to look in the real. You've seen the video yesterday, so you have quite a nice imagination, but for a better imagination for not doctors, not ophthalmologists, there are a nice draw which shows you how we perform the vitrectomy, plana vitrectomy. Basically, we perform free incision into the eye through the anatomical structure which we call the pars plana. From this is the name. One, it's an infusion, and we infuse this balanced salt solution into the eye, and in the other there are the light source, and the rest is the vitrectum, which is the most important part, which cut the collagen fibers and remove it from the inside of the eye. And by this mechanism we are able to remove all the vitreous and approach for the retina to treat the diseases on the surface or behind the retina, or many other indications. So, as Einar mentioned, after the start to perform vitrectomies in the early 70s, the clinicians find many consequences, and most important was increased risk of development of nuclear sclerosis of the cataract. The other was the reduction of neovascularization of the retina. The other was increased risk of glaucoma. And the last was the increased risk of anterior chamber neovascularization, which we call the rubeosis iridis. It has been already mentioned. But what have all these diagnoses in common is the oxygen. So this is the scheme introduced by Nancy Hollenkamp, and it shows you basically the situation in the vitreous before vitrectomy. So we have a retinal vessels with a high saturation, and this oxygen diffuse into the vitreous cavity and create the gradient inside. And the middle part of the vitreous, there are the very low level and low saturation of the vitreous, which protect the lens, because this oxygen create a progression of cataract and the other consequences, which has been shown as a clinical consequences. So, because the oxygen have a very central position in the pathology of the vitreous removal, but it's not a pathology, but the consequences is probably the better word. The oximetry is a very suitable tool for investigating and measuring the changes, and it was our work. So we use the T1 oximet for measuring the changes before and after vitrectomy. We use the standard for this measurement, we use the standard method, and we create concentric cycles, which is 1.5 and 3 times bigger than optic disc in the center, and we measure all the values and calculate the average consumption for or average saturation for arteries and average for veins, and by the subtracting this we create the AV differences. So In 2014 there was published 2 pilot studies which showed us that there are significant changes. First was mine study, and we've described the increase of oxygen tension in the veins after vitrectomy, roughly the 3% increased, but statistical significant, and the very same result has been published by a group of limb and collaborators, where they found not only the increase of vein saturation but also the arterial saturation, but both of these studies was on a very small sample, so we need to we was forced to enlarge the cohort and create a new deeper insight with more information which we can obtain from the results. So in our current cohort we have 82 eyes of 82 patients, which was indicated for retinal surgery. In 25 cases it was a diabetic retinopathy patients with a non-proliferative diabetic retinopathy. 34 was operated because of presence of macular hole, and the 23 was operated because of epiretinal membrane. These 2 diagnoses, macular hole and epiretinal membrane, it's a group, or it's belong to a group of diagnoses which we named as vitreoretinal interface diseases, and it's depending on difficulties or in changes of the posterior hyaloid membrane detachment. So basically we could say that this group of these 2 diagnoses have almost intact retina. There are only a small pathology in the macular region, and of course the diabetic patients have a basic diabetic retinopathy disease, so it's there could be some differences. Average age of the group you can see, and the ratio of male and female is presented here. We focused more deeper on this, and you can see the differentiation of this, and what you can see, MH is a macular hole, ERM is a epiretinal membrane, and DM is a diabetic retinopathy. But we later focused on a lens status in these patients, and basically we have 3 groups because we have a 1 year and 52 weeks of follow-up, so it's quite long. So basically we had 3 groups. First was the patient which entered the study with the artificial plastic lens after the cataract surgery. The second was the patient with the natural lens, inside, and remaining with the natural lens through the whole of the study. And the last group was the patient which underwent phacoemulsification, which means the cataract surgery during the follow-up. All of these cases was operated in between the follow-up point on a 8 week and on a 52 week before the end of the study. I will show you it later. This is important because there are some differences in results. Okay, so and now for a result, the arterial saturation. Basically, in all patients, when we combine all the groups, there are very slight increase in arterial saturation. Even there are the p-value statistical significant, but increase is just roughly the 1%. It's a little bit strange, of course, because this change, even if it has been described by the Singapore's colleague, it's very difficult to explain, and I think that we can for vein saturation where the situation is much clearer. In overall situation, again in all patients there are increased approximately 3-4% of increased. There are the baseline point. Then there was a pars plana vitrectomy, and we have two checkpoints. First was on a week 7 and the second was on a week 52, and you can see the increase of vein saturation. But if we focused more deeply on a different diagnosis, you can see that this is true for a patient with a macular hole and epiretinal membrane, so one could say with a normal peripheral retina, but group with a diabetic patient did not obtain such an increase like the two previous. Yeah. There are slight but not statistical significant. And when we focused on a subgroup according to lens status, you can see that the pseudophakic patient with the artificial lens have increased, and on both checkpoints in a follow-up there are approximately the same value of increase, but the group with a natural lens have obtained the increase in the first checkpoint and then slight dropping of the saturation on the week 52, and FACO group, which is operated during the flow-up, have a very slight increase in the beginning between the baseline and the week 7, but then they rise and they reach almost the same saturation, vein saturation as the pseudophakic patient. So this differences gives us a very true indication that there are some artificial effect of the lens status and especially of the density of the lens. So let's say the cataract could be said. Okay, the last results was AV differences. So in this, again, we can see the opposite results. From approximately 33% of saturation, it drops approximately about 2.5%, and it remains in all patients. But when we look at the subgrouping, again, the macular hole and epiretinal membrane group had the same pattern like the overall situation. But the diabetic group, again, there are the difference, and there are no such a high decrease of AV differences in that group. And again, this not reach the statistical significance. So we can clearly see, or we can clearly conclude that the diabetic patients have a little bit different physiology or a little bit different changes of saturation after pars plana vitrectomy. And what is interesting, if we look at the differences according to lens status, in this AV differences, there are in almost all cases the very same situation. In all cases, there are the decrease, and it remains same on the week 7 and week 52, approximately the same. Again, in all cases, it reached the statistical significance. So this is one of the most strong indicator that the differences according to lens status in a vein and even in an arterial saturation is the artificial, because this is subtracted in AV differences when we calculate both of them. And the last things we evaluate in our study was a vessel diameter, because as has been shown before, the diameter of the vessels indicates the status not only the saturation of the retinal vessels, but also of the retinal tissues. And in all cases here you can see that there are some slight decreased. The only exception is a macular hole. We don't know why in this case it's a different, but in all other cases there are the slight narrowing of the vessels, and it could indicate the improving of the tissue saturation. So probably even in a diabetic patients, even if they do not have a increase in saturation in the retinal vessels, the tissue looks the tissue saturation looks increased in this group. So if we put all this information together, we can go back to the first slide, or the slide where we describe the oxygen level in vitreous cavity. And after the vitrectomy, even if the gradient between the inside of the vessels and in the center of the vitreous remains, we know that the saturation or the level of oxygen after vitrectomy is increased. It was described by using the magnetic resonance imaging, and it was also described by the theoretical model provided in Basel or Geneva, I am not sure. So from this point of view, the question is why in the diabetics, where we know that there are clinical improvement of neovascularization, is not increase of vein and vascular saturation. And I think that it is because oxygen can diffuse freely from the anterior part of the eye in the case after the vitrectomy, and this oxygen is consumed by the hypoxic tissues, and in a normal patient this oxygen need to be flow out from the tissues by the vessels, but because in diabetics the tissue is already hypoxic, this extra oxygen is used for a physiologic function, and in a veins remains the same level. It's one of the possible explanation of our findings from the last study. So in conclusion, we can say, and this need to be mind for next research, because the clinical trials is underway on many sites. So the vitrectomy eye have a little bit different physiological, measurements and level of saturation. So this need to be keep in mind, and I think that for investigating the other diagnosis, this need to be exclusion criteria, and the cataract have an effect of increased saturation, but in this case it looks that it's an artifact, and again it needs to be keep in mind for future studies. Thank you.